Hello, everyone. Welcome to the first of two blood-brain barrier opening question and answer sessions. My name is Richard Price. I'm a professor at the University of Virginia, and I'll be co-moderating this session along with Nathan McDaniel, who is a professor at the Brigham. We're joined by four presenters today who are in the technical session. The second session is going to be another section, which is going to cover essentially everything that's not covered in this small session. So our presenters today are Antonios, Maria Eleni, Sergio, and Francesca. So right now I'll turn it over to Nathan for the first question.
Hi, thank you, Richard. So the first question is for Sergio Jimenez. And he gave a very nice presentation on using creating lenses that are create holographic focusing. The question from the chat is, how reproducible is the holographic lens from animal to animal? And how many multi-spots can you make? And also, can you change the position of the focus during sonication with the lens?
Well, thank you very much for my presentation. Well, from animal to animal, it mainly depends on how similar the skulls are from animal to animal. In this case, the mice were the same age, so we could use the same lens for different animals. But for example, if we think more in humans, we have to design a particular lens for each skull, but we can use the same lens, not with the same quality results, but we could. How many multi-spots? It depends mainly on the wavelength of the ultrasound. And in this case, we designed the lens to create two foci, but we could create 3, 4, 5. Of course, not very close one to each other, but it depends on the wavelength of the frequency. And yes, we can move the lens to move the position of the focus, but the ideal thing would be to design a new lens to compensate the aberration exactly in that position of the skull. But we can still move the lens not very far away, but keeping this aberrations compensation through the skull.
Thank you. One thing that I noticed in your talk is that you used a microbubble dose of 1 microliter per gram of weight, and that seems like a really high dose. Can you comment on that?
Well, I did this research in collaboration with Columbia University, with Antonios Paulos here, and Alisa Conofago, and well, they were the experts in that part. But previously, using the same frequency with the same transducer, they could open the BBB in mice, so we did the same.
All right, thank you. I'm going to hand it back to Richard for the next speaker.
Yeah, so a question for Maria Eleni. Would this technique work equally well in white and gray matter?
So we've shown in the past, and Nathan has shown also, that there is more vascularity in the gray matter. So it is easier kind of to say that we can open the barrier in gray matter compared to white matter. That's why we targeted gray matter in this case. But since we're comparing and the analysis is relative prior and after the BBB opening, I believe that we could see FA changes in white matter as well.
Okay, let me ask you a little follow-up question too. So if you were to think about comparing DTI to a standard sort of DCE sequence that we use now for examining barrier opening, do you think there are any advantages or disadvantages with respect to, say, sensitivity at a given field strength? Or is there any other comparisons that you might make that are interesting between those two modalities?
So DCE, definitely, it's DCE with gadolinium, right?
Yes. Mm-hmm.
So DCE definitely gives the advantage of having a contrast agent. However, for us, it took at least 30 minutes to allow gadolinium circulation and another 30 minutes to acquire, at least in primates, the entire DCE sequence, so we had all the time points there. For DTI, it took just 10 minutes, and it was a medium DTI, which means that we had 15 different directions. We could go higher and we could go more sensitive. So we were relatively moderate. So it can be even more sensitive and without contrast. So the hope is to figure out ways where we can identify the small changes in the susceptibility of the brain and the changes of the BBB opening, avoiding gadolinium or any other contrast.
Thank you.
All right, I have a couple of questions for Antonios, who gave a talk on disrupting BBB in primates with a neuronavigation system, guided system. So the first thing that was really interesting about your talk was that you see some evidence of improved cognition after the BBB opening. So it's not that you saw a lack of damage, you saw actual improvement. How do you think that is occurring? What do you think is going on there?
Yeah, that's a great question. In short, we don't really know, but we have some hypotheses. So when you open the BBB, because there are a lot of downstream effects. So one of them is change the functional connectivity. You also cause some neurogenesis, as I showed in the talk. So, these downstream effects, in the short term, affect the cognitive function. And we see these effects waning down over time. But we think it's a combination of functional connectivity changes and neurogenesis, and generally the brain trying to come back to homeostasis. But yeah, this has to be investigated in future studies with rodents, because you need a lot of numbers and statistical power to see these effects.
You don't think there's any sort of training effect in the tasks that you're looking at?
There is a training effect for sure, but these monkeys were trained beforehand, so they had reached their saturation period of performance. And as I said, this change is short-term, like there is a big jump right after FUS, and then over time it slowly decays. So we believe it has to do with the BB opening and downstream effects.
I had a question about the cavitation monitoring that you're doing. And you did some experiments you showed where you're detecting the harmonics through a human skull. What were you actually sonicating in those experiments?
Yeah, so that was a very simple experiment. We had just a tube flowing, with microbubbles flowing through the tube, and we focused the ultrasound beam at this tube, and we put the skull on top of it. So this is a really minute concentration of microbubbles, but still we could see harmonic emissions rising above the control. So we believe, and we've seen it actually recently with our first human, that we can actually see cavitation through the human skull with this PCD.
That's
in the future,
yeah,
we want to replace that with an array and do passive acoustic mapping in real time, and that will be our subsequent improvement of the setup. But at the moment, we just want to see that we avoid any kind of unwanted effects by avoiding or minimizing broadband emissions.
Thank you.
So, Francesco, a question for you. Do you think that your work will correlate cavitation dose, your microbubble imaging method, will that correlate with a cavitation dose during blood-brain barrier opening? You're muted.
I would say that's a very great and difficult question to answer, but in general, yes. The answer is yes. And the observer can be translated to over BBB. There are two factors that should be taken into account. One is the amount in an area of bubble in time. And the other that we are studying is the mean transit time of the bubble, because not only the amount of bubble is heterogeneous in the brain, but also the transit time is different. So in arteries, the flow is very fast, whereas in capillaries, the bubble, they transit very slowly. So we are doing now some preclinical work in an in vitro model, and we are doing some microbubble imaging. And we do see, using planar transducer, that with the same amount of pressure, we observe different amount of microbubble, or blood-brain barrier opening according to the microbubble density. And ideally now we're in human, we're correlating, we want to correlate the contrast enhanced ultrasound imaging that we perform during surgery with perfusion MR. And correlate it and hopefully obtain a non-invasive biomarker for microbubble distribution in the human brain.
So let me sort of dovetail another question into that discussion. And when we think about blood-brain barrier opening for infiltrative tumors, what we really want to do is open the barrier in the infiltrating rim to enhance the delivery of the drug there. So with your microbubble imaging approach, do you see differences in like the infiltrating rim versus the tumor mass and the surrounding brain tissue? Do you have that kind of sensitivity?
Yes, no, definitely. When we talk about GBM, for example, the distribution of the microbubble is similar to that of gadolinium. So you really, in GBM, you enhance the bulk of the tumor. And there are no big differences between the surrounding areas of the tumor and the, let's say, healthy brain tissue around.
Okay, thank you.
Sure.
So I have a question for Antonios if we're seeking questions here. Antonios, in your study, your day 2 histology, you looked at neurogenesis using DCX, which is a common stain for neurogenesis, and you also looked for microglial activation. Did you happen to have the ability to see whether those were actually correlated spatially with each other?
Very nice question. So we didn't do microglia and neurogenesis together, but we did neurogenesis DCX and astrocytes together on the same slide. So we could see a lot of activation of astrocytes in the area where we could see these blobs of DCX positive cells. So there might be a link there. We don't have enough data points to claim that's universal, but we saw this trend that they used to be close to each other. So there must be some connection between immune response and this neurogenesis effect. That's what we believe, yeah.
Okay, thank you.
I have another question for Sergio about the acoustic lenses. How do you see this being used if you scale this up to a human? Because most of the treatments that people are contemplating are going to be targeting fairly large parts of the brain. Are you going to have a lens for each location, or are you going to have a lens that creates a, sort of negates the skull, and you can then move the focus around?
Yes, well, very nice question. This is mainly our idea. Just in humans to create a lens, for example, to cover the whole hippocampus with one single sonication, just in one position of the transducer. But the whole thing, this is like the hologram, the 3D hologram. So we could cover the whole hippocampus or both hippocampi in both hemispheres of the brain or the putamen but yeah, with one lens.
I have a sort of a general question that that anyone can discuss, not necessarily about the work they're presenting today, but in general about blood-brain barrier opening. One of the things that we found in doing going to the clinical trial is that we're not able to use the same microbubble dose that we are in our animal studies. And so I was wondering how, if we needed to do a reduced dose, and that's from the FDA limits on DEFINITY, as if we need to reduce the dose, how do you think that will impact translating the stuff that you've been working on and presenting at this meeting?
Well, we have to assess it because we started first in mice, but
yeah, I can answer that. So normally in mice we use 1.5 megahertz or something like that, right? More than 1 megahertz. The problem with DEFINITY is that the expansion ratio is not enough to open the blood-brain barrier at 1.5 megahertz at the clinical dose. So in humans or in monkeys, we have to reduce the frequency so that we increase the expansion ratio of these bubbles, because DEFINITY is quite small. So we've seen that in monkeys especially, opening the barrier with 0.25 megahertz is way easier than 0.5 megahertz with a DEFINITY clinical dose. So we have to adapt at least the frequency when we scale it up to humans.
And I would like to, my, let's say, clinical experience with imaging, which is slightly different from BBB opening. So I've been using Sonoview in roughly 600 patients, 700 patients. I want to highlight the fact that there is a really inter-individual variability. So the same dose from the factory can produce a different imaging, a different amount of microbubble and this is sort of unpredictable. So one thing that I think that could be done in the future, when we translate to the clinic, is to find a way to establish how much bubbles are circulating in a specific individual at the moment of the treatment.
Do you think administration route affects the outcome? So if it's like a bolus or infusion, what's better, you think?
Infusion definitely is better. I think infusion, we're working with a preclinical model and we're doing infusion and the amount of microbubble is constant. Actually, I mean, in our model, there is not a real circulation. So how much, there is a certain amount of bubble that arrives and a certain amount of bubble that goes out. So there might be some accumulation. When you perform a bolus injection, you reach sort of steady state that lasts for 2-3 minutes after the peak. So if you take, we can take advantage of that. But the amount of microbubble changes in time, so it decreases slowly. So probably infusion is better.
Okay, well, great. I think unless anyone else has any questions, we can wrap up this session. Thank you, Richard, and the speakers for today.